the structure, genome, and replication. So structure, it's most of it, I think, is what you know, family, Picorna viridae, hepatovirus, size is just 27 nanometer. It's a non-enveloped virus. So it's a quasi-enveloped, which means it requires the membrane or for the envelope from the host. It derives it from the host. So it's a non-enveloped, it requires the host, okay, for producing a membrane. Genome, 7.5 kilo base pair, single-stranded RNA. So what you need to know is that the size and all may not be all that important. Size is important when it comes to hepatitis B. Otherwise, what you need to know is that all of them are basically single-stranded RNA except hepatitis D, hepatitis B, which is a DNA virus. Structural and non-structural proteins are there. Sorry, you have to learn this by heart. There are 4 structural and 6 non-structural proteins. Exclusively in the hepatocytes. So it's a hepatotropic virus. Virus can also be found in the mainly in the liver, bile, blood, and in the stools. So when does the maximum viral shedding happen? It's during the pre-symptomatic or the late incubation period. So when the late incubation period, that or pre-symptomatic stage means the patient doesn't have any symptoms. So you don't even know if the patient with you is having symptoms or not. That is when they are most infective. So by the time they go into the symptomatic stage, that is by the time they develop icterus, nausea, vomiting, fatigue, and all, you have already been exposed to it if you're staying with that person. Okay, so that is why maximum infection occurs during the late incubation or the pre-symptomatic stage or the pre-icteric stage. That is when maximum, because that is when most of the hepatic viruses are hepatotoxic only, ma'am. Yeah, most of the hepatic viruses are hepatotoxic, but all that you have to know is that it's usually because of your immune response. Okay, so that is why these you meant this viral hepatitis only, no? Most of hepatic viruses means hepatitis A to E or EBV CMV. Hepatotropic viruses, yeah. Hepatotropic viruses. Okay. So you have the replication is in the hepatocytes, but you don't have any extra hepatic reservoir for hepatitis A. Fine, but for hepatitis B, you have extra hepatic also. So that is why even if you do a liver transplant for a hepatitis B patient, you have extra hepatic reservoirs. For example, the pancreas, some of them the lymph nodes, the spleen. They may also have this, the bone marrow. So what happens? Those patients, even after transplant of the liver, they can still get infected. So that is one thing. The hepatitis A usually doesn't have that extra sources. It has extra hepatic manifestations, like your evanescent rash, or you have the cutaneous site vasculitis, but not extra hepatic reservoirs. Okay. Unique feature is quasi-enveloped, circulates in the host-derived vesicles, and host range usually is humans, experimental stage primates, and families. 15 to 45 days is the incubation period. Mean is around 30. It's on fecal-oral transmission, your hepatitis A and E. Maximal viral shedding, late incubation, and early before the onset of jaundice. So how do you make out a diagnosis? IgM anti-HAV. Okay. Hepatitis A antibody IgM. So the patient's IgM, which means they're having an acute infection. After 6 months, it becomes IgG, just like any other disease. So if a patient is having IG, when you're looking for hepatitis, don't screen for IgG. Always screen for IgM. Fine. And post-illness, HAV RNA is detectable by RT-PCR for months, but it's not infectious. So when is the most infectious stage? We learned it's your late incubation or pre-symptomatic. Okay. Environmental stability is resistant to drying, ether, acid, moderate heating. So you have to boil for very high temperature. Textbook says 1 minute, but these days our SPM studies also show that you might have to boil for 15 minutes, even if it is a RO water, which you're having at your home, which all of us usually depend on. That also doesn't filter the hepatitis A. And there are some studies which have shown that there's cross-contamination happening across apartments. So you have to boil even the RO water for at least 15 minutes. Okay, and chlorination also, that is from other water bodies externally. Formaldehyde or UV radiation. There is no chronicity. There is no carrier state. There is no cirrhosis. Remember that. So pre-incubation or incubation, that is late incubation of the pre-icteric, that is when fecal HAV virus shedding, and peak viremia also happens. ALT rises after that during the early acute phase, which is usually diagnostic of infection. During there, you have IgM anti-HAV, which is positive, which is diagnostic of acute. IgG replaces this. It stays positive. It's a lifelong immunity. Recovery is what? It's what ALT normalizes and there is no carrier state as well. So this is what it shows. Usually within 15 to months after exposure is what has been Any genotype of hepatitis A which is more virulent, ma'am? No. There are some genotypes, but it's there. You don't have any studies also to show that this genotype or that genotype. Generally, hepatitis A, that's it. There is no, there are no tests to determine that. Okay, so if your hepatitis A is positive for a patient, just make sure the patient doesn't go in for any fulminant liver failure, and the other contacts have been immunized. That's all you can make sure. Okay. So HAV is shed in the feces, your liver, the bile, serum, and the stools. So these are the most infective HAV carriers. Jaundice develops usually just after that, serum ALT. Then your ALT gradually normalizes, your IgM anti-HAV becomes positive, and IgG stays for life. Serology, acute infection, IgM is positive. Past infection, IgG. Neutralizing antibody is usually protective. Basis, so IgG is a neutralizing antibody. So this is what is taken for a patient who has had a history of IgG. You have their plasma has been taken, which contains IgG anti-HAV, and that is what is given as immune globulin. So immunoglobulin, not immune globulin, it's immunoglobulin. Okay, immunoglobulin for post-exposure contacts. So either for sexual contacts or for household contacts of hepatitis B. This immunoglobulin is actually passive immunization. That is, the antibody is what is taken in. We'll be coming to that. Who are the people who need to take it and what is the dose? We'll be coming to that. Okay. Now, commonest cause of symptomatic viral hepatitis in children and adolescents in the developing nations is hepatitis A. And improving sanitation, there is a shift. It's more of trick cases. There's no chronicity, carrier state, relapse. The fulminant is less than 1.1%. Prevention, active and passive. So now what the studies say is that vaccine is as effective as your immunoglobulin. So you do not have to give immunoglobulin as such, okay? But if at all you're giving it, you have to give within 2 weeks of exposure itself. Otherwise, your vaccine is as effective as immunoglobulin. And vaccine is given as 2 doses, one today and one 6 to 12 months later. Okay, so one stat, 6 to 12 months, 2 doses. They usually do not provide a lifelong immunity. So it's only about 5 to 10 years, probably. That's all. After that, their titers also will reduce. So you have to check the titers later on in life. But if it's an attack of hepatitis A which you've had, they usually provide lifelong immunity. So it's usually by the fecal-oral transmission, and hence safe food and water. Hand washing is important. Periodic foodborne outbreaks like shellfish, berries, milk, because often these are not cooked, they're not heated, they're not boiled. That's why. Okay. 17-year-old student presents with 5 days of malaise, nausea, dark urine. An examination, mild hepatomegaly is noted. Mild ictus and tender hepatomegaly. ALT is in thousands, IgM positive, IgM HAV positive, HPS negative. History reveals a recent consumption of street food during a monsoon attack. So even if you say monsoon attack, what they have given is IgM HAV. So don't get misguided by something else. And I know you know what it is. It's a fecal-oral transmission. There's no carrier state. Now, hepatitis B virus, Hepatna viridae, it's a DNA virus, 3.2 kilo base pair, circular, closed, covalently closed circular DNA, cccDNA. So that is what is specific of this hepatitis B, because hepatitis B replication requires a reverse transcriptase activity and an RNA intermediate. So none of these viruses require an RNA intermediate except hepatitis B. So that is why you have a cccDNA, covalently closed circular DNA. That is the DNA of the hepatitis virus. It gets fused with the host hepatocyte nucleus, and then there is a reverse transcriptase happening. Okay, so once a patient's hepatitis, the cccDNA is already integrated into the host, what happens? It remains infected for life. That is why hepatitis B virus, even surpassing the stage of chronic cystine or cirrhosis, it can go directly for hepatocellular carcinoma, because cccDNA is already integrated into the host. Why is it integrated? Because only then can it produce a pre-genomic RNA, which is an intermediate from which the new DNA can be produced. So you have basically, they come as 3 particles. One is spherical, and you have the filamentous 22 nanometers. And you have the 42 nanometer, that's a Dane particle, 42 nanometer double shelled, and nucleocapsid 27 nanometer plus the DNA polymerase, whereas the subviral particles, they are just excess of virions. So they contain only HPS AG. Okay. Then you have the envelope antigen. HBs is present on the surface. The core antigen in the nucleus, you have the HBC, which is present. HBe is a soluble marker. So these are the different antigens. Entry of hepatitis B is by sodium taurocholate co-transporting polypeptide. It is the same channel which helps in hepatitis B. So B and D always they coexist. So B doesn't require D, but D requires B. And both of them enter through the chain channel. D cannot outlast B. Always remember that. So these are the different particles. Spherical particle, you have the tubular and you have these are the spherical, the tubular particles. Both are 22 nanometer. The other one is 42 nanometer, which is the large one. This is your Dane particle, which contains your HPSAG. It contains a nuclear capsid and the DNA polymerase, which is inside. So whenever the nuclear capsid is present, there should be a nuclear material inside. So that's your DNA polymerase. Whereas this one doesn't contain that. They are just excess of HPSAG. So HPSAG, that is your green things, no? HPSAG. Those are the only things which are seen for these patients. Only these forms. Whereas the other Dane particle contains even the nuclear capsid. So you have the spherical as well as the filamentous forms which are present here. So what are the different, you have your ORF, which is actually a very compact structure. I mean, your genome, which is a very compact structure, and it contains the open reading frame, mainly the S antigen, you have the C, you have the P, the DNA polymerase, and the X. So your S plus you have pre-S1, pre-S2. So this is the structure. So this is your open reading frames, which are important. It's a very compact genome. You have your S, you have your pre-S1 and your pre-S2 as well. This is supposed to be 1 and this is supposed to be 2. Okay. Then you have DNA polymerase, which is for your P. Then you C codes again are mainly for your HBC antigen. Your pre-C, which codes for your HBE antigen. And you have your X, which is transactivating and transcriptional properties. Okay, so this is what your genome actually contains. So how the replication happens is, so which are the antigens? C, which is never found in circulation because it doesn't have an envelope. You have S and you have E. So these are the antigens, and the antibodies would be, I mean, more than antibodies, HBV DNA. That is what you're supposed to look at. Okay. So first you have the virion, which comes in, attaches to the sodium taurocholate co-transporting peptide. So once it comes in, it undergoes uncoating, and once the HPSAG, so that is lost, uncoating, what is inside the nucleocapsid with the DNA polymerase. So that enters inside, and you have the covalently closed circular DNA, which then forms the reverse transcriptase. It forms the mRNA. This is your RNA intermediate. So that happens inside the nucleus. This is the nucleus. So once this RNA intermediate is synthesized from the cccDNA, this comes out, and then through translation, you have many proteins. Encapsulation occurs, and through this RNA intermediate, you have the reverse transcriptase activity, the DNA polymerase, which is produced for the new protein, or the new virions. So first, uncoating happens, then the capsid and the polymerase inside, cccDNA inside the nucleus becomes the mRNA. This mRNA, what happens? mRNA, that's the usual thing. DNA, RNA becomes proteins. So there are protein particles which have been produced. Apart from that, through this mRNA intermediate, you have your DNA polymerase or your reverse transcriptase, which helps in DNA formation as well. When mRNA intermediate. So the proteins plus the DNA polymerase, all of this undergoes encapsulation. They become proper viruses. So once the viruses have been produced, this is your endoplasmic reticulum. Okay, so once the viruses have been produced, either they go out of the cell or some of them again re-enter into the nucleus and they produce more and more cells. So this is the replication cycle of hepatitis B. Is it clear? Dane particle complex hepatitis D. This is just the electron microscopic view. You have the small film. This is your Dane particle. These are the spherical forms. You have your filamentous forms. All are 22 nanometer. This is your Dane particle, which also contains the HPSAG. Okay? Right. So these are your proteins which have been produced. Hepatitis B disease progression. This is about hepatitis B. So acute infection happens. You got a good response. 90 to 95% of the patients, they clear the virus. Less than 5% goes into chronicity. So once they go into chronicity also, they are only having a chronic hepatitis. They're not having cirrhosis. Okay. Chronic hepatitis, about 20 to 30% of them, they can become cirrhotic. Some chronic hepatitis directly, they can become HCC. See, 5 to 10% of the patients who are infected with chronic hepatitis, they become HCC. This is what is your de novo HCC. Directly from chronic hepatitis, they become HCC. Some of them from cirrhosis, here also they can decompensate. So 23% of the patients decompensate within 5 years of developing cirrhosis. Otherwise, so the complications are chronic cirrhosis, decompensation, cancer. But once the stage of cirrhosis happens, the only thing which can save them permanently is liver transplant. In fact, even after liver transplant also, you don't know, because of the extrahepatic reservoirs, they can continue to be infected. So which is the first marker to rise in any hepatitis B? It is HBsAg, which rises usually within 1 to 2 weeks. So what is the incubation period? It's anything up to 180 days. Okay, it's the longest incubation period for hepatitis B, 180 days. HBsAg usually, so if you get a needle prick and you want to check if the patient was HBsAg union, and if you are HBsAg, the earliest you can check is even after 1 to 2 weeks. But within 3 months, ideally, you should be positive, if at all you are incubating it. Persistence of more than 6 months indicates a chronic infection. Anti-HBs is what appears. So what happens in any infection? First, you have antigen. Antigen comes off, and then you have the antibody which rises. So HBsAg initially will be high. And then you have HBsAg comes down gradually. If it persists for more than 6 months, it's chronic infection. But otherwise, once it normalizes, the antibodies to HBs develop. So that's your anti-HBs antibodies. Whereas HCV, hepatitis, sorry, not HCV, in HBsAg, the C antigen, it cannot get secreted in the serum, so you can never find it in the serum. Instead, what can you find? The antibody against HBc, which is IgM anti-HBc. That is the next marker to rise. That's within few weeks of HBsAg itself, you have your IgM anti-HBc. At the same time, you have HBeAg or EAG also, E antigen also, which rises. So all the 3 antigens, basically you can say HBs is the first thing. Then within few, you have HBeAg. IgM anti-HBc alone, remember, never say HBcAg. Okay, only IgM anti-HBc will be seen. So these are the first few to rise during a patient with acute viral hepatitis. Right? Once HBsAg becomes negative, then only anti-HBs is positive. Once HBeAg becomes negative, anti-HBe is positive. So this process of HBsAg becoming negative and anti-HBs turning positive is what is HBs seroconversion. Similarly, when your HBe antigen becomes negative and anti-HB becomes positive, that is again a seroconversion. So when the patient is seroconverted, which means they have become serologically, antibodies have formed, there's no more antigen. That is when you say that the patient is having good protection now. Okay. HBV DNA, it's a quantitative replication marker. 5 to 10 international units per ml is the lowest sensitivity. It guides therapy. It's very important. Always remember, acute viral hepatitis, you do not have to give any you don't have to give any nucleotide analogs. When you have to give nucleotide analogs is when the patient is having coagulopathy or encephalopathy, fulminant hepatic failure. There you can give nucleotide analogs, and that should be given at least 3 months after HBeAg disappears. Till then, you have to give nucleotide analogs. Fine? In a patient with acute hepatitis E. So there's something called as a window period, and this concept we'll be coming to in this. Okay, we are having so this is your, so HBsAg, the first marker to rise, it's usually within 3 months itself, it will be up. Within that, you have HBeAg also around the same time it's rising, plus IgM anti-HBc. Fine? So there'll be something called window period that is here, that your HBsAg has come down, but your anti-HBs is not yet improved. It's not, the titers are not come. But during that time, what is only positive? Still, you can have IgM anti-HBc. So that is your window period. HBsAg is negative, anti-HBs is not positive, but your IgM anti will be positive. Okay. So that is your window period. That is the sole diagnostic clue. Window period means anti-HBs. Anti-HBc, IgM anti-HBc. So you have various genotypes, A to J. All these genotypes are there. You have many subtypes also, A, DW, ADR, AY, WAYR. These are various subtypes. But why is it important that you have to know what are the genotypes? Some of the genotypes, they respond well. Earlier, before nucleotide analogs were used for treatment of chronic hepatitis B. You have interferons were used. So these, some of the genotypes, they respond well to interferons. So that is what is, those are the ones. Okay, so the ones which respond well to interferons are hepatitis A. So this is the order of response. Shorter time to loss of treatment with interferons means HbA should be lost, which means the patient is recovering well. So A responds best, B responds after that, then C, then D. So this was the order of response to interferon. Similarly, the chronic hepatitis A, that was, chronic hepatitis B was usually seen in non-A. So A was basically having a good prognosis. Then shorter time to HbA seroconversion, which means shorter time means what? Soon the patient became anti-HbE positive, which means good chance of recovery. So that was again for hepatitis B when compared to C. HCC risk was greater for B genotype, not hepatitis B, sorry, it's for genotype B when compared to genotype C. HCC risk was greatest for hepatitis B. So it was dangerous again in younger age group in Taiwan, but greater in C in older age group in Japan. So these were some of the, so this was the only thing why genotyping was important. But otherwise, these days, just because a patient falls in different genotypes, it's all the same nucleotide analogs which have been using. Except in some conditions where, the treatment is the same, but pre-core mutants. So this is important. So why is this important? It's important because in some Mediterranean countries, what happens is HBeAg, so pre-core, pre-C, that is what is supposed to produce HBe antigen. So when that is not present, so what happens? The patient will be HBeAg negative. So you might think that the patient is good, HbA is positive, but the HBeAg is negative, but not so. It's because of the mutation that the patient is HBeAg negative, and it is not because they are healthy. But these patients, you should be all more careful because they will not be having HB. Usually HBeAg is a marker, or it correlates somewhere to hepatitis, HBV DNA. It's almost parallel to HBV DNA, especially in chronic infection. So a person who's HBeAg, what you will expect is HBV DNA is less. So lesser the viral replication, the better the patient is. But pre-core mutants, they do not have HBeAg, but their HBV DNA will be very high and they show increased action. Activity will be very high. So LFT will be increased, and that means there is increased inflammation happening. Ideally, you should start treatment for them. Okay, this is when you're talking about chronic hepatitis B. I'll be coming to that later. What you need to know that pre-core mutation is because you have A to G. There's a codon which is changed. G1896. Okay, sorry, G to A. Okay, G to A at 1896, which results in stop codon. And because of stop codon, there's no HBeAg. So that's why pre-core mutants are more common in the Mediterranean countries. Second one is escape mutants. So escape mutants are, they are escaping, which means even if you give a vaccine or immunoglobulin, they are not actually, it's not helping, which means a person who is having, who has already had vaccinated, which means like you or me, okay, we would have had vaccination, but if you continue to get hepatitis B, that means what? It's because your vaccine has actually escaped. Your hepatitis B virus has actually escaped the vaccine and is produced. So that is usually produced in some where you have an alpha determinant immunophenotype, okay, alpha determinant which evades anti-HBs or the vaccine. Okay, that's one thing. And also in immunoglobulin. So one is vaccine, which is passive immunization. The other one is an active immunization, that is immunoglobulin. So post-liver transplant patients also, even if you give hepatitis B, say for example, a patient was hepatitis B positive, you did a liver transplant for them, which is the definitive thing for cirrhotic liver. After that also, they continue to get hepatitis B virus is going on multiplying despite giving the immunoglobulin. That means there could be an escape mutation. So following vaccine as well as following immunoglobulin. So if they continue to have, which means they are escape mutants. So these are the two mutations what you need to know. The pre-core mutants where HBeAg is not being synthesized. So HBeAg will be negative, but there'll be chronic hepatitis. And how do you find that out? You have to do HBV DNA and your ALT. Escape mutants is vaccine and immunoglobulin escape. Then therapy induced. That is YMDD motif mutation in polymerase, DNA polymerase. Okay, so that results in lamivudine resistance. So when there is a YMDD mutation, that will result in lamivudine resistance. Extrahepatic reservoir is the lymphoid, bone marrow, pancreas, and transplant recurrence. So that is responsible for the transplant recurrence. These are some of the geographic distribution. What you need to know, some of them, Southeast Asia, India comes in D. But now you have increased migration across continents. You cannot restrict yourself, cannot do anything. Why was that important before? But always remember, whatever genotype you're falling in, the treatment is always nucleotide analogs. Treatment is always nucleotide analogs. Okay, so shorter time to HbAg seroconversion, A, B, C, D, in that order. HbAg loss also. Interferon treatment, A, B, C, D. Shorter time to conversion, B was always considered better. Then you have evolution to chronic liver disease. It's least with A. So just remember, it's least chronic disease, more to genotype A, but the slide is different. Which slide? This one? Yeah, actually, that is there. See, chronic disease is more with genotype A. This is actually from Slisinger. That's right. It's not from Harrison. This thing I took it from Slisinger. That's right. Okay. Then infection phases are acute self-limiting infection. Okay, so acute self-limiting infection is when the patient is having acute infection, all the markers you look for. C, obviously, you cannot see HPSAG, HPEAG, HBV DNA, ALT, SGOT, PT. So all of them, if you look for HPSAG is positive, EAG is also positive, ALT is peak. Gradually, what happens if it is self-limited infection? HPSAG becomes negative and anti-H becomes positive. Similarly, HPEAG becomes negative and anti-HPAG becomes positive. LFT also, initially it will rise at the time of acute infection, then gradually it will lower down. Jaundice also disappears. But what remains throughout? It's your IgG anti-HPC. So IgM has become IgG. So this is what is proof that you earlier had a hepatitis B infection. Chronic hepatitis B is if you have HPSAG persisting for more than 6 months. So if a patient has HPEAG persisting for more than 3 months itself, you can think that they're likely to go in for chronic HPEAG. Okay. But if the HPSAG persists for more than 6 months, and be sure they are going for chronic hepatitis B. Replicative phase, that is the early phase, where there is high HBEAG, there is high DNA, there's maximal infectivity and injury which is happening. Okay. But later on, you have a phase of seroconversion. So HBEAG, that happens about 10% of the phase. This is for chronic hepatitis B. This is not for acute. Please remember. So non-replicative later on, 10% per year, there is a seroconversion which is happening. Always remember, even when there is a seroconversion, when your ALT is elevated, that is when you have to do treatment. That is when treatment is required. If your ALT is negative, seroconversion has happened, HPSAG is positive, which means what? The patient, if your ALT is negative or it's low, that means within 35, the patient is an inactive carrier. Is only an inactive carrier, but already the host, the CCG DNA is integrated into your host DNA. So that's why there will be some amount of replication which is happening. But ALT, it's not much, it is still lesser. Reactivation risk is always 5%, they revert back. So even if they're inactive carrier also, they can suddenly revert back. So inactive carrier, what will be your, so in a patient who is having an immune tolerant phase is what? You have your immune tolerant phase, you have your immune active phase, you have your inactive carrier phase. So these are the different phases of chronic hepatitis B. And you have sudden reactivation. So the sudden reactivation can happen from any of these phases, either from here or from here. They don't have to be in succession or anything. Immune tolerant phase means what? Tolerance. So where have we found the tolerance? That is when children who are born to mothers who are hepatitis B, they are the ones where their immune system is tolerant to the hepatitis B. So that's what immune tolerance. So children who are born to such mothers, they are the ones who have HPSAG would be positive. E antigen would be positive. So when E antigen and S antigen are positive, I don't have to tell you, the antibodies are obviously negative. HBV DNA would be very, very high. So just because HBV DNA is high, even 10⁻⁷, then all will be there. Just because the HBV DNA is very high, you do not have to think there is heavy replication and you have to start treatment. No. Look at your ALT. ALT would be normal if it's an immune tolerant phase. So which means the patient doesn't require treatment. But if you go into the immune active or the immune clearance phase, for example, so that usually happens at about 10% per year. That means E antigen becomes negative and you have your anti-HBE which becomes positive. So what happens? They're trying to clear. So there's increased seroconversion. And in the process, what happens? Your LFT increases or ALT will increase. So whenever this ALT is high, then definitely you have to start treatment for them. Some of the patients, what happens is S antigen alone may be positive. E antigen may be negative. But again, if it's a pre-core mutant, you never know. Still, there'll be E antigen negative, but the activity will be there. So what you have to do, you have to look at the ALFT. So your ALT, if it is normal or if it's less than 35, which means is an inactive carrier. But reactivation, which means what this HBeAg negative was, they suddenly reactivate means S antigen, as usual, it will be positive. E antigen also can turn positive. Most important is IgM anti-HBC. That becomes positive. So whenever you have an acute infection or even a reactivation, your IgM anti-HBC will be positive. This again, you require treatment. So when does reactivation occur? That is commonly when the patient undergoes any chemotherapy or any immunosuppressant medication, simply like an infliximab, but the patient is taking, there itself they can undergo. So any immunosuppressant the patient is taking or any chemotherapy or any organ transplants, they also will be on immunosuppressants to reduce the rejection. In such patients also, suddenly there will be reactivation. So infectivity correlation, always HBeAg have got highest infectivity.